Good morning. My topic for today's presentation is posterior scleritis in a child. My patient is a 10-year-old resident of Bangkok since February 2023. She developed ocular complaints of swelling, redness in right eye associated with pain for 2 days. Her systemic complaints were low-grade fever, nausea, vomiting with intermittent abdominal pain. Relevant history of viral fever lasting for a week in the month of April. No complaints of diplopia, no history of upper respiratory tract infection, treated as conjunctivitis with topical antibiotics. Pediatric consultation was done and she was treated symptomatically. From 6th to 12th June, there was incomplete resolution of symptoms and she was started on topical steroids. On 12th June, there was no resolution of symptoms, reappearance of lid swelling, right-sided headache and low-grade fever which subsides on its own. From 14th to 15th June, there was periorbital edema which increased, persistence of redness, systemic condition of lethargic, nausea, vomiting continued with low-grade intermittent fever. Then on 15th June, she had painful ocular movements in all gazes in the right eye. Her visual acuity unaided was 6/6 in both the eyes with IOP normal in both the eyes. Anterior segment examination of right eye showed periorbital edema, chemosis, congestion with no RAPD. Posterior segment examination of right eye showed media clarity grade 1 with optic disc edema and rest within normal limits. Left eye examination of within normal limits. This was CE-MRI brain and orbit report of Bangkok, which suggested proptosis in the right eye with involvement of lateral rectus, superior rectus, inferior rectus, lacrimal gland, which showed mild thickening and enhancement. With the history and with the course, they have diagnosed as it as orbital cellulitis over orbital inflammatory syndrome, right eye, and suggested for parenteral antibiotics. She moved to Lucknow, that is Center B, and she was started on IV antibiotics, Targocid, ceftriaxone. Along with that, she was started on 1 mg per kg body weight oral prednisolone. She responded well. Her preseptal edema settled down, nausea, vomiting disappeared, chemosis improved. This was the MRI brain and orbit axial scan, which showed increased posterior scleral thickening, but the periorbital inflammation reduced, proptosis also reduced compared to the previous MRI. This was ultrasound AB scan, which showed disc edema and subtenon fluid collection, suggestive of posterior scleritis. The diagnosis was orbital inflammatory syndrome. When she presented to our center, she was already on tapering dose of steroids, and the symptoms were resolved. Her examination, ocular examination, revealed 6/6 vision in both the eyes unaided. Ocular movements were full and free in all directions and gazes in both the eyes. Color vision was normal. Contrast sensitivity was normal. Anterior segment examination was normal in the right eye with no RAPD. Posterior segment examination, fundus showed grade 1 media clarity with disc edema, and rest of the examination was normal in the other eye. This was the fundus showing grade 1 media clarity and the optic disc edema of the right eye, and this was the left eye image, which is normal. My differential diagnosis, this is the long list of my differential diagnosis. We have thoroughly investigated her, and her CRP was increased, ESR was increased, and other rheumatoid factor ACE and ANCA and ANA profile was all negative. AB scan showed, which was done on 5th July, showed disc edema, T sign which suggestive of posterior scleritis. Axial scan showed increased retinochoroidal thickness with T sign. My final diagnosis was idiopathic orbital inflammation with posterior scleritis. Given the need for prolonged immunosuppression, she was initiated on oral methotrexate, continued for 2 months, then started on biologics, adalimumab. Now patient has symptomatically she is free, and presently she is on adalimumab. These are my references. Thank you.
So methotrexate, what is the dose that was started?
Ma'am, she was started on subcutaneous, ma'am. Maximum dose was given was 20 mg, ma'am. It was given for 3 months from August, September and October. Then she was shifted to adalimumab. Subcutaneous adalimumab, she was given 20 mg.
Okay. Any specific treatment you could make, because all those tests which you did, was it an autoimmune disease? Like you started antibiotics, you started steroids, then adalimumab?
That disc edema could be pediatric sarcoidosis also. We have ruled out sarcoidosis. There may be IgG4. We have ruled out IgG4, ma'am.
So from the test, nothing could come out positive.
Yes,
so it was exclusion. It was a diagnosis of exclusion that it is autoimmune, and you started on adalimumab.
Yes, ma'am. Yes. there are literature suggests that there will be a posterior scleritis, and later on they may develop Conn's disease or any other autoimmune disease.
Because with now adalimumab is just like panacea for so many diseases. So just can you tell what all you have to be careful for a young patient and others also? If the patient is on adalimumab, you have to be careful about some of the systemic problems. Can you tell?
Ma'am, there may be demyelinating disorders which may unmask at an early age. Demyelinating disorders which may unmask with adalimumab. Otherwise, local reaction.
Even tuberculosis have to be checked
Ma'am.
again and again because it is
Tuberculosis,
suppressant, immunosuppressant.
No. There was a point, ma'am, we did not do ocular tissue biopsy as we did not get consent from the parent. And when patient has presented to us, she was asymptomatic, except the disc edema. Others were, there were no signs of periorbital chemosis.
If you were to do a biopsy, from where will you take the biopsy?
Tissue biopsy, ma'am, if she has painful ocular movements, we would try to take from the muscle.
The immunosuppressive therapy, are you, is the rheumatologist or the medicine department is
We
doing,
have
or you're
taken
doing it yourself?
consultation of rheumatologist, ma'am, in consultation with rheumatologist.